You know that feeling when you're trying to get your head around something really important, but it just feels like you're swimming in a sea of information,
Yeah, absolutely.
especially when we're talking about complex stuff like why people struggle with things like substance use.
Mm-hmm.
We're going to try and cut through all that today,
Yeah.
get straight to what really matters.
That's exactly right. And we've got some really fascinating material here that dives deep into understanding substance-related and addictive disorders.
Okay.
Our sources, they lay out this framework. It includes 10 different classes of substances.
10. Wow.
Yeah, everything from, well, the familiar ones like alcohol and even caffeine. Though there's an interesting exception there we should probably get to.
Caffeine. Yeah.
Right. And then things like cannabis, opioids, stimulants, you name it. And what's really, well, thought-provoking is that it also includes gambling.
Gambling, as in not a substance.
Exactly. A non-substance related disorder, but it shares some key underlying features, which is quite interesting.
Well, so what we're aiming to do for everyone listening today is build like a clearer understanding of this whole area.
Right.
We're going to look at how these disorders were actually defined, what the crucial symptoms are, the things professionals look for, and maybe touch on some of the thinking behind why they develop and the different ways people can get help.
Yeah, the etiology and treatment approaches.
Think of it maybe as getting a solid mental map of a really complex but incredibly important part of the human experience.
And the great thing about this deep dive is it's all based on established diagnostic guidelines and detailed discussions around, what contributes to these disorders, how they're approached in treatment, and also why relapse can be such a challenge.
So we're grounded in the evidence.
Exactly. We're not just speculating. We're looking at what the experts in the field have actually put together.
Okay, so let's jump right in then. The first thing to get our heads around is what a substance use disorder actually is. Our sources give us a pretty clear definition from the American Psychiatric Association. It says it's a cluster of cognitive, behavioral, and physiological symptoms, indicating that the individual continues using the substance despite significant substance-related problems.
So basically, it's that pattern, isn't it? Ongoing use, even when it's causing serious issues in someone's life.
Yeah, that persistence despite the problems.
And what's fascinating here, it's not just about, occasional use. The sources really emphasize that to be diagnosed, this pattern has to include at least 2 specific symptoms.
2 or more.
Yes, occurring within a 12-month period. It really highlights that this is about a persistent and problematic relationship with a substance.
Right, and these symptoms, they aren't just random issues, are they? They tend to fall into 4 main categories. I find that helpful kind of organizing it.
Yeah, that framework is useful.
The first is what they call impaired control.
Okay.
This looks like using more of a substance that you originally intended, maybe, or finding that your use just stretches on for much longer than you planned.
Right, losing track.
Yeah. It also includes those like repeated but unsuccessful attempts to cut down or get your use under control.
Trying but failing.
Exactly. And spending a significant amount of time either getting the substance, using it, or maybe recovering from its effects.
This takes over your time.
And that really intense feeling of craving, we've all craved things like chocolate or something, but this sounds like a whole different level of persistent desire, doesn't it?
Absolutely. It's that feeling of being driven to use that seems to take over.
Okay, so that's impaired control. What's next?
Then we have the category of social impairment.
Oh, okay.
If we connect this to daily life, this is where substance use starts to really interfere with your responsibilities.
Like work or family?
Exactly. Think about struggling to keep up with things at home, school, or work because of your substance use, or continuing to use even though it's causing friction and problems in your close relationships.
Even when people are telling you it's a problem.
Right. And tragically, it can also lead to people giving up or significantly reducing activities that used to be important to them, hobbies, social events, things they genuinely enjoyed.
Wow. It's like the substance becomes the central focus, pushing everything else into the background.
Pretty much.
The third category is risky use. This one feels particularly serious.
It definitely is. It's about using substances in situations where it's physically dangerous.
Like driving, you mentioned.
Like getting behind the wheel of a car after using, or continuing to use, even when you're aware that it's making an existing physical or psychological problem worse.
So you know it's bad for you, but you keep doing it.
That continued use despite knowing the harm. It's a really stark indicator. It underscores the powerful pull these substances can have, often overriding rational thought and self-preservation.
Okay. And the last category.
And finally, we have the pharmacological criteria. This involves the concepts most people have heard of: tolerance and withdrawal.
Right. Tolerance and withdrawal.
Tolerance, as many people understand, is that need to use increasingly larger amounts of a substance to achieve the same desired effect.
Ah.
Or noticing that your usual amount just isn't having the same impact anymore.
Diminished effect.
And withdrawal involves experiencing those often unpleasant physical and psychological symptoms when you reduce or stop using a substance that your body has become accustomed to.
Like the shakes or feeling awful.
Exactly. Or even using more of the substance just to keep those withdrawal symptoms at bay, using to feel normal, essentially.
Now, our sources make a really interesting point here.
Mm-hmm.
You can actually receive a diagnosis of substance use disorder for almost all classes of drugs,
Almost all, yeah.
with one notable exception: caffeine.
Right.
I think a lot of us can certainly relate to relying on our morning coffee, maybe feeling a bit groggy without it.
Definitely. Headache, maybe?
But it typically doesn't lead to the same kind of deeply negative and harmful consequences that we see with other substances. What do you think makes caffeine so different in this regard?
Well, that's a crucial distinction, isn't it? The potential for significant negative impact on health, social functioning, overall well-being. That seems to be a key differentiator.
So the level of harm is just not comparable.
Generally, no. While caffeine can certainly have physiological effects, maybe make you jittery or disrupt sleep, the patterns of compulsive use and the severity of negative consequences usually don't reach the level seen with other substance use disorders.
Okay, that makes sense.
The sources also highlight some important specifiers that can be added to the diagnosis. These give more detail.
Specifiers, like what?
For example, someone can be in remission. Either early remission, meaning they haven't met criteria for a little while but less than a year,
Okay.
or in sustained remission, which is longer, 12 months or more. That offers a really hopeful perspective, you know?
Yeah, shows recovery is possible.
Definitely. There's also the specifier of being in a controlled environment.
Like a treatment center.
Exactly, like a residential treatment program or even incarceration where access is restricted. And then, of course, there's the level of severity: mild, moderate, or severe.
How is that decided?
It's determined by the total number of symptoms the person is experiencing. Mild is maybe 2-3 symptoms, moderate 4-5, and severe is 6 or more.
Got it. So it gives a sense of the intensity.
Precisely.
And this is where things get really interesting in terms of everyday language. The term addiction. We hear that all the time, right? In the news and conversations.
Oh, constantly.
But our sources point out that it's not actually a formal, specific diagnostic term within the DSM-5, which is like the standard guidebook for mental health professionals.
That often surprises people. It's not an official diagnosis itself.
But it does appear quite frequently in general discussions and in research, doesn't it?
Absolutely. And it's often used to describe that really strong, often uncontrollable urge or compulsion to use a drug.
The core features we discussed.
Exactly. The development of tolerance, the experience of withdrawal. So, in a way, addiction functions more as an umbrella term that people use, often referring to a more severe substance use disorder.
That's a helpful way to think about it. It captures that feeling of being caught in a cycle, maybe, despite wanting to stop.
Exactly. It really captures that sense of lost control. Now, let's maybe shift our focus a bit and think about the underlying reasons. Why do these things happen?
The why.
What are some of the prevailing ideas about why these disorders develop in the first place? Our sources touch on a few key perspectives on what's known as etiology.
Okay, etiology that causes. So one of the older ideas mentioned is Conger's tension reduction hypothesis. That goes way back 1956.
Yeah, quite a foundational idea.
The core idea here is that substances like alcohol can have the effect of reducing negative emotions, anxiety, fear.
Making you feel better temporarily.
So the thinking goes that people might initially start using these substances as a way to feel better in the short term, and over time, this becomes a learned coping mechanism, eventually leading down the path of addiction.
It's like a form of negative reinforcement, isn't it? You use the substance to take away something unpleasant?
Right, remove the bad feeling.
What's particularly interesting about that early hypothesis is its focus on that immediate emotional relief the substance provides. Then we have a different perspective that emerged from Marlett and Gordon in 1985.
Okay, what do they propose?
They approach addiction less as a way to reduce tension and more as an overlearned maladaptive habit pattern.
A bad habit that's gotten really ingrained.
Kind of. Think of it like any other behavior that becomes deeply ingrained through repeated practice, even if it ultimately have negative consequences for the individual.
That makes a lot of sense, too. It's like the brain essentially gets wired, right, to associate the substance with certain situations or emotional states, creating a powerful learned response.
Exactly. Those cues become really powerful. And then more recently, our sources highlight what are known as biopsychosocial models.
Biopsychosocial. That sounds broader.
It seems like a much broader and more comprehensive way of looking at things, acknowledging that there isn't just one single factor that leads to addiction.
Not just one thing.
Precisely. If we connect this to the bigger picture of human experience, these models recognize that the development of addiction is most likely the result of a complex interaction between several different types of factors.
Like what kind of factors?
These include physical factors like an individual's genetic predispositions, their brain chemistry,
Biology.
right? Then psychological factors, which might involve personality traits, coping skills, the presence of other mental health conditions like depression or anxiety.
Mind and behavior.
And sociocultural factors, such as a person's social environment, their cultural norms around substance use, access to support systems, poverty, stress.
The world around them.
Exactly. So it's really a confluence of different influences that can contribute to someone developing a substance use disorder. It's rarely simple.
Okay, so it's complex.
Yeah.
Now let's talk about what happens when someone recognizes they have a problem and wants to seek help. What do the sources say about common treatment approaches? It sounds like it's rarely just one single thing that works.
That's absolutely right. The most effective treatment strategies often involve a combination of different approaches, typically integrating psychotherapeutic interventions, there are various forms of talk therapy, and in some cases, the use of medication.
A combined approach.
Yeah.
And there are quite a few different types of talk therapy mentioned, right? Cognitive behavioral techniques seem really prominent.
They are, with specific examples like contingency management.
What's that?
That uses a system of rewards, basically, to encourage positive behavioral changes, like staying abstinent.
Okay, incentives.
Yeah. Then motivational interviewing, which focuses on helping individuals explore their own reasons for wanting to change, building that internal motivation.
Helping them find their why.
Exactly. And relapse prevention training, which we should definitely dig into a bit more later.
Okay, what else?
Family and couple therapy are also highlighted as potentially crucial. Makes sense, right? Addiction impacts the whole family system.
Absolutely. Relationships suffer.
And then, of course, there are the various 12-step programs and other self-help groups like AA or NA. They provide that community of support and a structured framework for recovery.
Peer support. Very important.
Hugely important for many people.
And what about the medication side?
When it comes to medication, the examples provided are usually very specific to the particular substance involved. For alcohol use disorder, medications like naltrexone and disulfiram are mentioned.
How do they work?
Well, naltrexone works by blocking the euphoric effects of alcohol, so it kind of reduces the motivation to drink. Disulfiram, on the other hand, actually causes unpleasant physical symptoms if someone drinks alcohol while taking it. A deterrent effect.
Makes drinking feel bad.
Right. For tobacco use disorder, nicotine replacement therapies, gums, patches, even e-cigarettes in some contexts can be helpful in managing those often intense withdrawal symptoms.
Easing the physical side.
Yes. Additionally, the antidepressant medication bupropion has also been shown to be effective in aiding smoking cessation for some people.
Interesting. Now, as anyone who has maybe struggled with this or knows someone who has, knows, the path to recovery isn't always a straight line, is it?
Far from it.
Relapse is a really significant challenge. Our sources emphasize that negative emotional states, things like anxiety, frustration, feelings of depression, are incredibly common triggers for relapse.
They're very common, especially in individuals with alcohol and other substance use disorders.
That seems to tie back to that initial tension reduction hypothesis we talked about, doesn't it? Feeling bad, wanting relief.
It does seem related, yeah. What's particularly insightful here is the psychological impact of the relapse event itself. Marlett and Gordon, again, they discuss what they term the abstinence violation effect.
Abstinence violation effect, what does that mean?
This refers to the feelings of self-blame, guilt, anxiety, and depression that can arise after someone experiences a lapse in their abstinence. They break their rule, basically.
They slip up and feel terrible about it.
Exactly. And unfortunately, these negative emotions can paradoxically increase the likelihood of further substance use. It can become a spiral. I messed up, I feel awful, might as well keep going. Creates a really challenging cycle.
Wow. So a seemingly small slip-up can unfortunately escalate into a full-blown relapse, largely due to how someone reacts to it emotionally. That's a really crucial understanding.
It is. Understanding that can help people be kinder to themselves if a lapse happens.
And that leads us to the idea of relapse prevention therapy, often called RPT. The core idea here is to proactively identify and manage potential relapse triggers, right, before they happen.
Exactly. Relapse prevention therapy focuses on helping individuals recognize and anticipate those high-risk
What
situations.
makes a situation high risk?
Well, the ones that tend to trigger negative emotions or expose them to cues associated with their past substance use, like certain people or places,
Oh, okay.
or situations involving social pressures to use again. Then the therapy focuses on developing specific coping strategies to navigate those situations effectively.
So planning ahead.
Pretty much. This might involve learning new skills for managing difficult emotions, using cognitive therapy techniques to challenge and change negative thought patterns like that abstinence violation effect thinking, and even making broader lifestyle changes to reduce exposure to known triggers.
Like changing routines or social circles.
Could be. The ultimate goal is to help people view a lapse not as a sign of complete failure, but as a mistake that can be learned from and used to strengthen their ongoing recovery efforts. A learning opportunity, not a catastrophe.
That reframing sounds really important. Now, our sources also place a specific emphasis on tobacco use disorder, a really critical area, obviously, given its widespread impact on public health.
Huge impact.
It's mentioned that quitting smoking has these remarkably positive effects on your health, like reducing your risk of serious cardiovascular events, heart attack, cardiac arrest, stroke.
Yeah, major killers.
Reducing that risk to a level comparable to that of non-smokers within a relatively short time frame. Just 1 to 5 years, it says.
That's truly incredible, isn't it? It highlights the body's capacity to heal itself once the damage stops.
It really underscores the remarkable resilience of the human body.
Definitely. However, as many people know firsthand, quitting smoking is notoriously difficult.
Really tough.
The sources point out that the vast majority of regular smokers are actually addicted to nicotine, which creates this incredibly powerful drive to continue smoking.
Why is nicotine so addictive?
Well, it's partly for the pleasurable effects that nicotine can produce, that little buzz or relaxation, but also very strongly to avoid the onset of those unpleasant and often intense withdrawal symptoms. Avoiding feeling bad becomes a major motivator.
And it's not just the direct effects of nicotine itself, is it? There seem to be other significant hurdles people face when trying to quit.
Oh, absolutely. Like the understandable fear of failure. Nobody wants to go through the effort of trying to quit only to relapse again and feel defeated.
Yeah, that must be demoralizing.
And particularly for women sometimes, the concern about potential weight gain.
Ah, yes. I've heard that.
Our sources note that it's quite common for people to gain a few pounds, maybe 5, 6 pounds on average, in the initial months after quitting smoking, which can unfortunately act as a real deterrent for some.
Even if the health benefits outweigh it massively.
Rationally, yes, but it's still a concern. And even after someone has successfully quit for a significant period of time, those powerful cravings can still unexpectedly pop up, maybe during stress.
Years later, even.
Sometimes, yes, creating an ongoing risk of relapse. It really speaks to the deep and lasting hold that nicotine can have on the brain.
Wow. But the good news is that research has identified a number of factors that tend to make successful quitting more likely, right?
Yes, there are predictors of success.
Okay, so what are some of those key predictors that our sources highlight?
Well, they mention things like being male seems to be a factor.
Interesting.
Being in an older age group, specifically 35 years or older, having a college education, living in a home where smoking isn't allowed, and working in a place with a smoke-free policy.
Social environment matters.
Very much so. Also, being married or in a committed partnership seems to help. Having started smoking at a later age in life rather than as a young teen.
Okay.
Having a relatively low level of nicotine dependence, maybe not smoking as heavily, and having experienced longer periods of abstinence in previous attempts to quit smoking specifically, managing more than 5 days without smoking before.
So past success, even short-term, predicts future success.
It seems to. That's quite a comprehensive list of factors.
It is, but it provides a really helpful picture of the various elements that can influence someone's ability to quit successfully.
And importantly, the sources also point to what makes smoking cessation interventions themselves more effective, what actually helps people quit.
Right. What works in treatment?
It appears to be a combination of things, using nicotine replacement therapy like the patch or gum to help manage the physical withdrawal symptoms.
Okay, the NRT.
Engaging in multi-component behavioral therapy. That teaches coping skills, provides strategies for relapse prevention, stimulus control, sometimes even things like rapid smoking under supervision.
So practical skills and strategies.
Yes, and having ongoing support and guidance from a healthcare professional or counselor. That encouragement and accountability.
So multiple components are key.
That multifaceted approach really seems to be the key to maximizing success. It's rarely just one thing.
Okay, so we spent a good amount of time talking about substance use disorders, where the primary focus is on that problematic pattern of using substances despite the negative consequences.
Right, the ongoing behavior.
But our sources also dedicate attention to substance-induced disorders. What's the fundamental distinction between these two categories? They sound related but different.
They are related but distinct. This is where the direct effects of a substance actually lead to the development of other mental health symptoms, things that look like other mental disorders. The sources define these as potentially severe, usually temporary, although sometimes they can become persistent, syndromes affecting the central nervous system. They arise either during or within about a month of substance intoxication or withdrawal.
Or from medication.
Or even as a result of taking certain medications, yes.
Yeah.
Examples would be substance medication-induced psychotic disorder or depressive disorder or neurocognitive disorders.
So it's not just about the ongoing pattern of substance use itself, but rather that the substance is directly causing other distinct mental health issues to pop up.
Precisely. The substance triggers symptoms that mimic other conditions, and there are some shared diagnostic features that are common across all of these substance-induced mental disorders, correct?
Yes, a few key things need to be present. Firstly, there must be a clinically significant presentation of a recognized mental disorder, like depression, psychosis, anxiety.
Okay, a real disorder.
Secondly, there needs to be clear evidence from the person's history, a physical exam, or maybe lab tests that strongly suggest a direct link between that mental disorder and either substance intoxication, withdrawal, or the use of a medication known to potentially cause such issues.
Yeah, to show the connection.
Right. Importantly, the symptoms cannot be better explained by another pre-existing mental or medical condition that isn't substance-related.
Can't be something else going on.
And they shouldn't only occur during a period of delirium, which is a separate state of confusion. Finally, these symptoms must be significant enough to cause clinically significant distress or impairment in the individual's life, social, occupational, etc.
Causes real problems. Okay.
Now, let's maybe zoom in on some specific examples of these substance-induced disorders. Alcohol-induced disorders seem like a big category here.
They are very significant. Our sources actually mention that alcohol is associated with almost all types of substance-induced disorders.
Really? Except which one?
The notable exception is obsessive-compulsive and related disorders. But pretty much everything else, depressive, anxiety, psychotic, neurocognitive alcohol can potentially induce those.
That's a pretty wide range of potential impacts. Speaks to how alcohol affects the brain, doesn't it?
It really does. It shows the widespread and complex effects that alcohol can have on brain function. Let's start with alcohol intoxication.
Okay, being drunk.
Essentially. The key indicators here are maladaptive behavioral and psychological changes. Things like inappropriate social behavior, impaired judgment, noticeable mood swings.
We've all seen that.
Probably. Occurring along with at least one of several physical signs, like slurred speech, poor motor coordination, and unsteady gait.
Stumbling.
Yeah. Those involuntary rapid eye movements known as nystagmus, impaired attention or memory. Or, in more severe cases, even stupor or coma.
Unfortunately, many of us have likely witnessed some of those symptoms at some point. Then there's alcohol withdrawal. That can be quite unpleasant, even dangerous, right?
Very much so. Our sources indicate that it's diagnosed when someone experiences at least two specific symptoms within a time frame of a few hours to a few days after significantly reducing or completely stopping alcohol consumption, especially after heavy, prolonged use.
What kind of symptoms?
These can include things like autonomic hyperactivity, excessive sweating, a rapid heartbeat, noticeable hand tremors, the shakes, difficulty sleeping, insomnia, nausea or vomiting. Experiencing sensory distortions like seeing or hearing things that aren't actually there. Those are called transient illusions or hallucinations. Increased anxiety. psychomotor agitation, that restlessness and fidgeting, and in more severe cases, even generalized seizures.
Seizures, wow. That sounds like it can escalate quite quickly and become a medical emergency.
It certainly can be serious, yes. And in some cases, alcohol withdrawal can progress to an even more severe condition known as alcohol withdrawal delirium, often called the DT's delirium tremens.
Okay, what's that like?
This is characterized by significant disturbances in both attention and awareness. Like, the person is confused, disoriented, along with marked difficulties in thinking and cognition. It's severe enough that it requires immediate medical attention.
Definitely need a doctor.
Absolutely. Alongside these cognitive issues, you'll often observe signs of that autonomic hyperactivity, again, increased heart rate, blood pressure, as well as vivid hallucinations, often visual or tactile, delusions, firmly held false beliefs, maybe paranoia, and pronounced agitation.
That sounds terrifying. Then there are the longer-term neurological consequences. Alcohol-induced major neurocognitive disorder sounds particularly debilitating.
It is. This involves a significant and persistent decline in one or more areas of cognitive function, memory, attention, language, executive function.
Thinking abilities.
Right. To the extent that it actually interferes with an individual's ability to live independently, manage their affairs. And our sources mention two specific subtypes.
Which are?
Non-amnestic confabulatory and amnestic confabulatory. The latter, the amnestic confabulatory type, is also commonly known as Korsakoff syndrome.
Korsakoff's, right. Linked to vitamin deficiency.
Often linked to a deficiency in thiamine, vitamin B1, which is common in chronic heavy alcohol use. This involves both significant memory loss.
Can't remember things.
Exactly.
Yeah.
Both anterograde amnesia, the inability to form new memories, and retrograde amnesia, the loss of past memories, and also confabulation.
Confabulation, what's that?
It's the unintentional creation of fabricated or distorted stories to fill in those gaps in memory. It's not lying per se. The person often believes the fabricated memories.
Wow, the brain trying to make sense of the gaps.
Kind of. It's a recognized and serious symptom. Finally, under alcohol, there's alcohol-induced sleep disorder.
Trouble sleeping.
Typically manifests as insomnia, yeah. This can occur both during periods of intoxication. Alcohol might initially make you feel sedated, fall asleep faster.
Pass out.
Right. But then it disrupts the sleep architecture later in the night, leading to more awakenings, reduced REM sleep initially, then maybe increased REM with vivid dreams, reduced deep sleep. Or it can happen more commonly during alcohol withdrawal, leading to severe sleep disturbances and often vivid and disturbing dreams then, too.
So it messes with sleep coming and going. It's quite sobering, really, to understand the wide range of problems that alcohol can directly induce, beyond just the use disorder itself.
It really is. Now, shall we turn our attention to some of the other substances?
Yeah, let's do that. What about stimulant intoxication? Like with amphetamine-type drugs, cocaine? What are the key signs and symptoms there?
Okay, so with stimulant intoxication, you'll typically see those maladaptive behavioral and psychological changes again. Maybe feeling euphoric or sometimes emotionally blunted, experiencing heightened vigilance, being jumpy or paranoid, feeling anxious or angry, exhibiting impaired judgment.
The psychological effect.
Right. And then there are usually at least two physical symptoms that develop during or shortly after stimulant use. This can be a wide range, too. Changes in heart rate, either speeding up, tachycardia, or sometimes slowing down, bradycardia. Changes in blood pressure, either up or down. Dilated pupils, sweating or chills, nausea or vomiting, significant weight loss over time.
Quite a list.
There's more. Psychomotor agitation, pacing, fidgeting or retardation, slowed movement, muscle weakness, breathing difficulties, irregular heartbeats. And in severe cases, confusion, seizures, or even coma.
Sounds very dangerous at high doses.
Extremely. And the period after using stimulants, often referred to as the come down or crash, that can be quite difficult too, right? What does stimulant withdrawal typically look like?
It can be very unpleasant. Stimulant withdrawal is generally characterized by the presence of at least 2 out of 5 possible symptoms that develop within hours to several days after stopping or significantly reducing prolonged or heavy stimulant use.
Okay, what are the symptoms?
Fatigue, just feeling exhausted, vivid and unpleasant dreams. Sleep problems, either excessive sleepiness, hypersomnia, or difficulty sleeping, insomnia. A significant increase in appetite. In either feeling markedly agitated or significantly slowed down in your movements, that psychomotor retardation again.
Feeling drained and out of sorts.
Exactly. The sources also specifically mention that following the cessation of high-dose stimulant use, individuals may experience a particularly intense crash, characterized by extreme lethargy, feelings of depression, and a notable increase in appetite.
That sounds pretty debilitating in itself. Okay, moving on to sedatives, hypnotics, and anxiolytics. This category would include things like prescription tranquilizers, benzodiazepines, sleeping pills.
Right, meds often prescribed for anxiety or sleep.
What kind of intoxication patterns do these substances typically produce?
In many ways, the presentation of sedative, hypnotic, or anxiolytic intoxication can be somewhat similar to alcohol intoxication. You see those maladaptive behavioral and psychological changes, inappropriate social or sexual behavior sometimes, poor judgment, shifts in mood, maybe becoming labile or irritable.
Similar to alcohol, then.
Yeah. Additionally, you'll typically observe at least one of several physical signs, including slurred speech, impaired motor coordination, an unsteady gait, nystagmus again, impaired cognitive functioning memory problems, attention deficits, or in more severe cases, even stupor or coma, all occurring as a result of recent use.
Okay. And what about the experience of withdrawal from these types of medications? Can that be dangerous too?
Yes, withdrawal from sedatives, hypnotics, and anxiolytics can also be quite serious and potentially life-threatening, similar in some ways to alcohol withdrawal. It involves the development of at least two symptoms within a few hours to a few days after significantly reducing or stopping use, especially after prolonged use.
What are those symptoms?
Again, you see autonomic hyperactivity, increased heart rate, sweating, noticeable hand tremors, difficulty sleeping, insomnia, increased anxiety, sometimes panic attacks, nausea or vomiting, transient hallucinations or illusions, usually visual, tactile, or auditory, psychomotor agitation. Yeah. And again, in more severe cases, the risk of grand mal seizures. So tapering off these meds under medical supervision is crucial.
Definitely not something to stop abruptly on your own. Okay, now let's consider opioid intoxication. We're talking about drugs like heroin, morphine, prescription opioid painkillers like oxycodone, fentanyl.
Right, a major public health issue currently. What are the telltale signs of intoxication with these substances?
The sources highlight the presence of problematic behavioral or psychological changes first. This might include an initial feeling of intense euphoria, the rush, followed potentially by apathy, lack of motivation, or a depressed mood, dysphoria, sometimes agitation or slowed psychomotor activity.
And impaired judgment.
And physically, the classic sign you'll typically observe is constricted pupils. They become very small, pinpoint pupils. Along with that, at least one of the following signs occurring during or shortly after opioid use: drowsiness or nodding off, sometimes progressing to coma in overdose, slurred speech, or impairment in attention or memory.
Okay. And opioid withdrawal is something we often hear about as being a very unpleasant and difficult experience, though usually not as immediately life-threatening as alcohol or sedative withdrawal.
Right. Extremely uncomfortable, often described like a very severe flu. What are the characteristic symptoms that someone going through opioid withdrawal might exhibit?
Following the cessation or significant reduction in opioid use after a period of prolonged use, or sometimes triggered by the administration of an opioid antagonist medication like naloxone.
Reversing an overdose can trigger it.
Exactly. An individual will typically experience at least three of the following symptoms: a dysphoric mood, feeling depressed, irritable, anxious, nausea or vomiting, muscle aches, often quite severe, watery eyes, lacrimation or runny nose, rhinorrhea, dilated pupils, the opposite of intoxication, goosebumps, piloerection or sweating, diarrhea, yawning excessively, fever, and difficulty sleeping, insomnia. It's a pretty miserable combination.
Sounds absolutely wretched. Okay, what about inhalant intoxication? This involves substances like toluene found in glue, paint thinners, gasoline, aerosols. Sounds particularly risky just due to the nature of the substances themselves.
Extremely risky, yeah.
Yeah.
Highly damaging. The sources describe maladaptive behavioral and psychological changes, maybe belligerence, assaultiveness, apathy, impaired judgment occurring, along with at least two of several possible physical and neurological signs during or shortly after exposure.
What kind of signs?
These can include dizziness, nystagmus again, poor motor coordination, slurred speech, an unsteady gait, lethargy or drowsiness, depressed reflexes, slowed psychomotor activity, tremors, generalized muscle weakness, blurred vision or double vision. In severe cases, stupor or coma. And sometimes, particularly with short-term, high-dose exposure, a short-lived feeling of euphoria. But the risks of brain damage and sudden death are very high.
Very dangerous stuff. And finally, we have tobacco withdrawal. We've already discussed some of the challenges associated with quitting smoking, but what are the specific symptoms that characterize tobacco withdrawal according to the criteria?
Right. So within approximately 24 hours of abruptly stopping or significantly reducing tobacco use, an individual will typically experience at least four of the following symptoms: increased irritability, frustration, or anger.
Feeling grumpy.
Definitely. Anxiety, difficulty concentrating, an increase in appetite, leading to that potential weight gain we mentioned. Restlessness, a depressed mood, and insomnia or other sleep disturbances.
That sounds familiar to anyone who's tried to quit.
Many people who have attempted to quit smoking can certainly attest to experiencing a number of these symptoms. It's a real physiological process.
Wow, that's a really comprehensive overview of both the substance use disorders and the wide array of substance-induced disorders. It truly highlights the complexity, doesn't it? And the far-reaching effects that these substances can have on the brain and on behavior
It really is. And I think it's crucial to keep in mind that fundamental distinction you made earlier.
between the use disorder and the induced disorder.
Yeah. Substance use disorders are primarily about that problematic and compulsive pattern of using substances despite the negative consequences, the behavior.
Right, whereas substance-induced disorders are characterized by specific mental health symptoms like psychosis, depression, anxiety, cognitive problems that are a direct result of the substance's effects on the brain, either during intoxication or withdrawal.
The symptoms caused by the substance. But, as you said, it's also important to remember that both types of disorders are serious. Both require informed understanding and appropriate intervention.
Absolutely. And as we've discussed regarding the different perspectives on what causes these disorders, the etiology, there's rarely a single simple explanation, is there?
No, it seems much more complicated than that.
It's usually that complex interplay of biological, psychological, and social factors that contribute to their development and make them so challenging to overcome.
And having even just this foundational understanding of these concepts, hopefully from our chat today, can really shift how we perceive and approach these challenges.
How so?
Well, maybe it can foster greater empathy and a more informed perspective. It's often easy maybe to pass judgment when you see someone struggling.
Mm-hmm.
But when you start to understand the underlying mechanisms at play, the brain changes, the withdrawal, the learned habits, the social pressures, it naturally leads to a more compassionate and nuanced view, I think.
Precisely. Understanding the why can reduce stigma and open doors to support. So maybe a final thought for you, the listener, to consider. Given this intricate and interconnected nature of biological, psychological, and social factors in the development and maintenance of substance use disorders, what do you personally believe might be the single most impactful point of intervention for individuals who are struggling with these significant challenges?
Where's the best place to start?
Is it perhaps focusing primarily on addressing underlying emotional or psychological issues through therapy? Or working intensely to change the individual's social environment and bolster their support systems? Or maybe prioritizing interventions that directly target the neurobiological aspects of dependence and withdrawal with medication or other biological treatments? Where might the biggest leverage point be?
That's a really powerful question to sit with. There's probably no single right answer, is there? It likely depends on the individual.
Very likely, but thinking about it highlights the complexity.
Well, this deep dive has certainly given us, and hopefully everyone listening, a lot to consider. And as always, it's really just the beginning of a much larger and ongoing conversation.
Absolutely. A starting point.
We strongly encourage you to continue exploring these important topics through reliable sources and engaging in thoughtful discussions. Thanks so much for joining us as we dove into this complex but vital area.
Thank you. It was a great discussion.